First of all, thanks to the organizers for bringing this together. SSG has really brought this whole conference to life, and it's really a pleasure to be here. I think to all the attendants, if you haven't had a chance to visit with industry, I would. They certainly are a big part of this. So with that, I'm just going to kind of give you a snapshot of what my experience with MIPS has been, kind of some pearls at the end, and obviously go through some cases, and hopefully this will be something that you can take home and might help you. Maybe bring some courage that you can do this in a very safe and reproducible way. So for this course, I don't have any disclosures. The goals of this is, what is MIPS? We have obviously that's why we're here. The why, advantages, disadvantages, cases, and again, some pearls towards the end of this. So MIPS, as we already know, is minimally invasive parafascicular surgery. It allows us as neurosurgeons to gain access to brain tumors and intracranial hemorrhages in a very safe way. And the whole part of this is, to safely navigate through the natural folds and delicate fibers of the brain to address those deep-seated pathological things. The goals remain the same for removal, right? You don't want to shortchange the patient, and when you're trying to remove these things, you still want to achieve the same goal, and that is to remove as much as you can safely. So parafascicular brain surgery allows us as neurosurgeons to take the natural corridors of the brain. There are some advantages and disadvantages, in my opinion. It's a minimally invasive. Advantages, first off, it's a minimally invasive procedure. It typically uses, small incisions, so it's less invasive. There's reduced trauma to the brain and surrounding tissue, so that's a big advantage for this technique. There's reduced recovery time. These patients are going to the ICU for maybe 1 to 2 days, and then they're home, inside of a week. There's lower risk of complications. Now, this brings about, some great expertise and experience. So the complication rates are typically lower than in traditional craniotomies. I think with the advanced imaging and navigational techniques that we have available, certainly there's improved precision and less postoperative pain due to the smaller incisions and smaller openings. The cost, again, overall, kind of more indirect. They're not spending tons of money, dollars in the ICU. So they get home quicker. Their rehabilitation, obviously, with their MRS, their modified Rankin scores going up or improving, this certainly helps the overall outcomes. The disadvantages, the other technique might not be suitable for all tumors. So, patient selection becomes very important. So traditional open craniotomies still have, its role. There are some technical challenges, so it requires some expertise. Pick your first few patients very carefully, and then move along to more complicated things later on. The risk of incomplete removal, again, that comes down to patient selection, right? So this could be potentially require additional surgical treatments. So be careful in your patient selection. Potential for neurological damage. Even though this is a minimally invasive procedure, there are still people that wake up with deficits. The whole goal of this is to do this very safely in a very efficient way. And the cost, we're using advanced technology, so it is going to bring about a cost. You do want to have the right support in terms of mapping, planning, navigation, et cetera, to be able to do these relatively safely. I think you've seen this from a number of the talks from yesterday that were really just mind-boggling of what you need to get this done safely. So with that, I'll kind of jump into what we've heard several times, the 6 pillars and, the mapping and planning, advanced imaging, optics. I do a lot of minimally invasive spine surgery. So I did use the exoscope for some time, but really I use primarily the microscope, particularly the cannulation and resection, and ultimately therapy runs out the 6 pillars. So in the first case, this is you're going to see a lot of this 20-year-old guy who presented with really just a history of hypertension, presented with left-sided hemiplegia. In this situation, you'll see kind of a lateralized right-sided hemorrhagic stroke. This gentleman was taken to the operating room about 6 hours or so. These are getting the preoperative sagittal axial images. The setup in the operating room, it's kind of what you've seen as a setup at many talks yesterday and also in the lab. One of the things I would say is that organize first, and then before operating. You don't want to get there and everything's all over the place, and you're trying to look while you're under the microscope or using the exoscope. Kind of go through this a couple of times to make sure you kind of know what you're doing and where things are located. Once that's done, obviously, just some intraoperative considerations. So brain relaxation, some people use mannitol for relaxation, hyperventilation. I don't use mannitol. I think the risk of brain shifting becomes an issue. So hyperventilation, just a slight bit, might help if you think you're running into a situation where the brain starts herniating out. Excuse me. Have a controlled evacuation, right? So cannulate and evacuate the hematoma. Remember, brain is time. And I think it's okay to recannulate if you're not really satisfied with the amount of pathology that you've actually removed. So with that, these are kind of the post-operative images. Gonna get vertigo with these screens moving, but I was pretty satisfied with the removal. And ultimately, these films can look really good post-operatively, but really where rubber hits the road is when you see these patients at 1 week, they're in rehab. This guy was a hemiplegic patient, and then at 3 months, he walked in my clinic without a cane. So definitely some really good feather in your cap when you see something like this. The next case, 41-year-old guy presented with pressure behind his eyes, dizziness, congestion, really no significant past medical history. He had a CT scan of his brain years ago, and the lesion was actually seen then. He returned with these symptoms, and the lesion had grown about 7 millimeters. And so outside, and there's a lot of images on here, I just wanted you to appreciate kind of the size of this thing. It was kind of near the anterior portion of the temporal lobe, near the clinoids, and it really climbed periventricular right next to the basal ganglia. And this, we thought, was probably going to be a teratoma because there were fat droplets you can see down on the right side of the screen. And there are some different densities within this lesion. Getting the same goals, I use DTI and tractography for all of my cases. In my hands, I think it's, even though sometimes there's some inaccuracies to it, at least in my hands, it's kept me fairly safe, somewhat. So these are more some sagittal images at the bottom, and then some more of the DTI and tractography. So moving on to kind of the post-op, I was really satisfied with the resection. This actually turned out to be a teratoma, germ cell tumor. You see on the left side of the screen that there's that was a traction injury, and I'm trying to, I guess, be heroic and take the entire capsule off, which really wasn't very bright. Obviously, you're going to leave some of that capsule behind. The guy had this little traction injury and developed an ischemic infarct. So when he woke up, and these are more sagittal coronal images and demonstrating really the removal of the entire thing, almost the entire thing. He woke up, and immediately post-op, he was completely phasic. He could not move the right side of his body. So I was obviously quite nervous, but I was confident in the trajectory that I took with the tractography on the DTIs. And so post-op day 1, he started moving his right lower extremity. His speech started to return. They have a lot of frustration when they're aphasic and whatnot. He's a young guy. Post-op day 2, he started, really his right leg was completely normal. He's back full, but his arm was still kind of trailing behind. A lot of ataxia in his right up extremity. And his speech really hadn't changed all that much. Post-op day 3, he was walking. His arm was almost back to complete normal status, with some mild ataxia, and his speech was almost back to normal. He left the hospital inside of 5 days, and at the 2-week follow-up, he was completely well. So I guess the tips of this, and some pictures. There's a picture of a tooth in there and some hair. I think the tips of this, the pearls of this, is that utilize the technology that you have, kind of trust your trajectories. And this wasn't necessarily unpredictable that it was going to happen, but I think the issue was that I was a little bit too heroic in trying to take out the capsule, and that's what caused it, not the failure of the navigation. The next case is 74-year-old female, left hemiparesis, worsening confusion over 2 weeks. And before she went to a chiropractor, which is kind of a little confused about that, with no improvement. Ultimately had a CT scan of her brain demonstrating this lesion in the right frontal lobe with quite a bit of edema and shifting. So this is the MRIs demonstrating a pretty significant ring enhancing lesion, and again below the DTIs and tractography imaging, and then the postoperative views. This turned out obviously to be a GBM, quite a bit of a malignancy. Left a little bit of tumor anteriorly, but overall I was pretty happy with the resection, and she left inside of 3 days from the hospital. And this is more of the sagittal views from this. And again, these are all through MIPS. These are not open cases. No, they're all through the MIPS technique. Next is an 81-year-old female, new onset of seizures, left upper extremity weakness with a facial droop over 2 weeks. She had a history of lung cancer with mets to her adrenal gland. She'd recently actually just finished radiation. She underwent CT and MRI, demonstrating actually 3 tumors. The one on the very left is more of a posterior frontal. There's a very small right inferior frontal lesion I didn't touch surgically, and then the right anterior frontal lesion. I cannulated twice for these 2 lesions. This was done as an awake craniotomy using the MIPS technique, and show you some postoperative images. Very satisfied with the resection. Cannulated both kind of at the same time, and then resected the posterior frontal first, and then the anterior frontal following that. It turned out to be an adenocarcinoma, metastatic adenocarcinoma, and she went home in 2 weeks. She had a little weakness from I think the posterior frontal lesion, but actually recovered quite nicely. Next case is a 6-year-old person with you're going to see a lot. Obviously, you've probably seen this in the ER, right? Opioid abuse, presented right facial drooping, right hemiplegia. These were supposedly all new onset. CT scan MRI demonstrated pretty significant hemorrhage here on the left side, and not to step on the vascular. This is nothing more like my last one for vascular, but intracranial tumor was taken out inside of 3 hours. The hemiplegia, this is the tractography and the DTIs. And again, I always use these. It just is in my hands and my thought process, and it helps. And I think repetitive doing this the same way helps a lot. These are getting the coronal and sagittal views of the DTIs and the postoperative images. She returned of function the very next day. And again, that's really very rewarding when you have an outcome like that, and you get patients through. Obviously, we have the enriched data and all that stuff's just kind of been proven. Getting them to the operating room soon. Brain is time. So last case I have, second last case I have, 44-year-old woman. This was a really sad story. Married, 4 kids, presented with all these new onsets of headaches, nausea, vomiting, photophobia. She is a smoker. She presented with this CAT scan and MRI, which has the looks of a butterfly glioma. These are more coronal and sagittal views of this. Again, the same tractography and DTIs are utilized in the preoperative arena. These are postoperative resections. I did leave some tumor along the pericallosals, not a whole lot, but it kind of started to ooze, and I didn't want to be, again, too heroic, but I was really satisfied with what I was able to achieve through the tube. And you can see the brain itself is not very disturbed. She woke up neurologically intact and went home a few days later. My last case is a 20-year-old guy who presented with this lesion, no significant past medical history, presented with dysarthria and headaches with a left hemiparesis and new seizure onset. This is the tractography and DTIs that were utilized preoperatively. I thought this was going to probably be a hemangioblastoma, or obviously on your differential polycystic astro or PXA, and it turned out actually to be a PXA. These are the postoperative images. And what was really key to this case was that the tube allowed me to maintain visualization. In an open corridor, you're going to have that cyst that's going to collapse on you. And the tube I was able to maintain visualization while resecting this, and it's quite nice to do it that way. So kind of in conclusion, avoiding complications in tumors, at least, and this is my opinions, imaging studies are very important. You want to have a multidisciplinary approach that will include neuro-oncologists, anesthesiologists, and really your surgical team has to be pretty competent what you're trying to accomplish with this type of technology. Patient assessment, everything isn't necessarily has to be done through the tube, but you can accomplish these things with patience and expertise as you move through. The surgical techniques, the minimally invasive approach, I love it. It's something that I use primarily now. Neuronavigation is, I think, key to this. DTIs and preoperative planning is very important. This kind of goes, I mentioned this before, the intraoperative considerations with hemostasis, but really brain relaxation. I typically don't use mannitol to avoid kind of the shift. Postoperative images on everyone, and really the same goes for the ICHs that are performed in terms of multidisciplinary approach, CT scans, MRIs, tractography, patient assessment, and the multidisciplinary approach. I think that's my talk. And the next.
Thank you, Jason. So before you close that down, So I'm going to ask the first question. Can you
Sure.
go back to that teratoma case?
Sure.
So one of the things that I think about, and I'd be curious to see what you think, Jeroen, is, if I have this hammer of using a tube, is everything a nail, right? And is this the right approach to do this? And my first thought on looking at this case is that the deep medial border of this is basically along the fissure, and you're gonna risk having lenticular striates and other perforators coming off bifurcation at the deep medial border. And if you approach this through a tube, that's going to be the last thing you see, and you're going to be approaching the perforators from the top down, as opposed to having proximal control. So this is personally, for my practice, a case where I would seriously consider not doing this as a MIPS case. I'm not saying that you can't do it as a MIPS case. I'm not saying it's wrong to do as a MIPS case. But as I think about complication avoidance, one of the struggles that I have through a tube, especially when you get to longer lengths of tubes, when you get above 55 to 60 centimeters or millimeters, sorry, is having enough play with your instruments at that depth, or even having instruments long enough to get good vascular control. Jeroen, what do you think?
Well, I agree. So I actually had a similar case, but it was a GBM. And so when I did the connectomics, I've had cases where the overlay of the speech will have me go either MIPS versus Transylvian. I think when I use a MIPS techniques and I know there's vascular involvement, especially in tumors, I am very careful to leave that for the end and then use cottonoids to really make sure I sweep those vessels, because it's very easy to go in and start resecting and not see the vessel and then breach that plane. So I think that's just something to be very cognizant of. I don't think it's contraindication to using MIPS, but I think that can be just a danger zone in MIPS cases when you have vascular involvement in tumors.
Yeah, the other concern I have is, you mentioned that in this particular case, they were hemiparetic post-op for the first couple of days, right?
Yeah.
Yeah.
Correct.
So, even though the MR shows I had a caudate infarct, that's probably anterior capsule, right? So that goes back to that probably being either a vasospasm or a small perforator watershed issue. Right. Comment?
First, I think it's a spectacular case, and it is ahead of the caudate event. And for those of us that have dissected the M1, this is a Huebner ischemia, right? Turning at the corner of the mesial portion of the sylvian fissure, you're going to get that. It's a teratoma. Right? If you think that you're going to finish this case without a Huebner spasm on a mesial lenticular striate, you've somehow defied the laws of physiology. So I think, you counsel the patient that he's going to have a caudate hit. He's recovered with an abulia and an aphasia at 7 days. I have maybe a little different perspective. I do a lot open. I would definitely consider this a MIPS consideration. You've gone lateral to the head of the caudate. You're in complete parallelity to the anterior limb of the capsule. The anterior limb of the capsule is pushed mesially. SLF is lateral to you. It's a perfect trajectory that you've dissected. And whether you meet Huebner at the beginning or you meet it at the end, the tumor's met it for a long time. And this is the tumor's interaction with Huebner. I think it's a beautiful resection. As you said, Jeroen, a pattern filled microcottonoid stuck in the base of the fissure for 10 minutes of the last portion of the dissection might be the only thing.
Thank you.
Any other thoughts or questions for Dr. Cormier?
Zach?
Yeah.
Yeah, great presentation, Jason. You mentioned using tractography, and I just want to know, do you have problems getting that if you're doing the case urgently or emergently? And what is your timing right now with all you've learned for ICH removal?
It hasn't really been that. In the beginning, it certainly was to get everyone on board. But I think, you get, I'll kind of call it credit in the bank if you talk to the radiology department, and the techs will get on your side because they think the technology is cool. And they're doing really all this, integrating the software to be able to get this done. And so when they do the MRIs, for me, they automatically do DTIs every single time. And it happens within, a couple of hours. but it took some time.
Jason, one last question. You showed a case where you did it awake, which is, a great option for complication avoidance, even with MIPS. And I think that patients will tolerate a MIPS cannulation better than an open craniotomy awake. Do you do any monitoring for the asleep cases?
Sometimes, but hardly ever. I prefer doing awake craniotomy. I think it's a better way to do it. I think it's more accurate.
Jeroen, what about you?
I mostly do asleep with, but then I use the MIPS as ECG, SSTPs in EEG. I have done some awake MIPS cases.
Thank you very much, Joseph from London. I would like to ask your comments on, you mentioned a case where you did 2 cannulations in the same patient, this one actually. I've never done that before. Do you do any imaging, intraop imaging in between the cannulations, or what?
I do not. No, I don't. I cannulate. So I think that if you do both cannulations, small, very small dural openings, you're not going to incur, a shift to the degree that you're not going to be off all that much. Now I don't have several, so I can't really speak on, a large volume of doing 2 cannulations at the same time.
I think it's quite interesting because most of the times, multiple meds straight away SRS. So MIPS can be an interesting approach for these cases where, the metastases are not exactly very nice SRS targets. So I think it's very good. It's a very good case. Thank you.
Thank you.
Yeah, and as we heard yesterday, ultrasound can be your friend in that situation where you finish the first, you're doing the second cannulation, you can ultrasound guide your cannulation to make sure you account for any shift. One other comment I wanted to make before we move on to Jeroen's case is for the larger intraaxial intrinsic tumors, gliomas, I've been burned once or twice where you don't give mannitol because you don't want any shift, you finish the case, but then post-operatively, they develop a pretty malignant edema. And so I've shifted for tumors, intrinsic tumors that are more than 2.5 to 3 centimeters. At the end of the case, I will give a full dose of mannitol on top of the steroids and treat them with hypertonics to try to, preempt any malignant edema that may occur in the first 24 to 48 hours. All right, why don't we switch over for Jeroen?
So my talk is going to focus a little bit more on ICH and a little bit in the kind of realm of that we have enriched, and then how you can push things a little bit and what the concerns may be. So I was a site PI for enrich in terms of disclosures. So complication in neurosurgery is generally accepted as a deviation from the normal post-op course occurring within the 30 days of surgery. So when we apply that specifically to MIPS and vascular cases, the real concerns are, as we've heard yesterday, really this emphasis on wanting to achieve a good end of treatment volume. So we want to be aggressive. We want to make sure our resections are clean, and we want to make sure that we leave very little postoperative ICH. We want to avoid rebleeding, and that leads into just surgical technique, timing of surgery. Again, we've alluded yesterday that, more and more we have track records, and everybody at this point in this room probably agrees that early surgery is really the way to go. Then there's this part about preserving the white matter tracts. So of course, as you remove the ICH, at some point you will encounter the interface with the white matter tracts. And the question is, how do you handle that? Because you really want to make sure that ideally you don't breach that plane and these white matter tracts are fully respected. And then you want to optimize your surgical corridor. And that's more and more relevant, especially for lobar hemorrhages, where sometimes, they're not always in the same anatomic position, and there can be some subtle decision-making as to whether or not you want to use anterior, lateral versus a posterior corridor. And we'll talk a little bit about the challenges that can come with that. So from a standpoint of treating ICH with MIPS, so it makes a lot of sense. We decrease the ICP, we remove the ICH, we avoid secondary injury. And so, in terms of how you do that, so there's some steps preoperatively that you already have to think about in terms of how you set yourself up for success. And so everybody gets a CTA. So at our institution, we've changed a little bit how the patients flow through the system in order to increase the efficiency. So after the CTA, that gets used as the reference image to navigate, and we use facial restoration. So that allows us to have patients go from the emergency room to the CTA straight to the operating room, or then go straight to the ICU. And then from there, if they deteriorate, go to the operating room. Otherwise, there's a lot of back and forth with extra imaging and there's a lot of inefficiencies in the system. We like to, keep a low footprint when we open the scalp and not have too many retractors in the way. So that's useful when you toggle an ICH, that you really can limit your craniotomy as small as you can and ensure that you have the full range to remove the ICH. You want to size your craniotomy based on the ICH anatomy. So these craniotomies are not always perfectly round, and you have to account a little bit, especially in lobar hemorrhages. If you have specific access, you're going to have to toggle that more. And then, one tip I've learned is attaching the shepherd hooks before you do the cannulation can save you a lot of aggravation because it's otherwise hard to snap on, and you want to create any flare abnormality or injure the white matter tract. So it's much easier to just put it on up front. Also, you may want to watch about putting it upside down or not, because it has a little ledge and you don't want it to then dig in the skin while you're doing the case and then limiting you. So those are just, easy little things. So, as we alluded yesterday, what we learned from MISTI 3 was really this end of treatment volume. And so independent of the size of hematoma, the more aggressive you are in your resection, as you preserve the white matter tracts, better off you are. And so as we've heard yesterday, it's very important for us to be aggressive and not just say we're going to remove what we can. We really need to focus on saying we're going to go for complete resections on ICH. If we look at when you start out, these were the inclusion and exclusion criteria for ENRICH. So as you apply it to practice, now they have a randomized control trial. So, the easy criteria when you start, you stick with volumes 30 to 80. Of course, as you get more comfortable, then you can push that. I've operated on hemorrhages above 100, but of course, those are more selective cases. GCS, there again, the range 5 to 14. But as you get comfortable, then of course you can build on that. Historical MRS of 0.1. In terms of exclusion criteria, so it's really you want to be aggressive on correcting the coagulopathies, and you just want to make sure that people have a reasonable life expectancy in order to justify the surgeries. The IVH one, so there's two issues in ICH sometimes that you have to watch out for. But the IVH can be a little bit of an issue. In the ENRICH trial, the IVH was okay as long as it was less than 50% of lateral ventricles. You can operate on more, but that has an increased morbidity risk just from the IVH, and so then you need to be a little more calculating, making sure you will address both well if you're going to take on cases that have very significant IVH. The other one is sometimes in the basal ganglia hemorrhages, there is some thalamic involvement. So in the ENRICH trial, you could have less than 25% of the thalamus that could have a little bit of hemorrhage, so that was still okay. But that could be selection criteria and you may want to be careful on. As we talked about yesterday, the evidence is very robust that MIPS is superior to medical management. It's very strong for lobar hemorrhage. There's still unanswered questions for basal ganglia where more research is necessary. So if we talk purely more about complication and what was published in the MIPS trial, so the overall mortality rate was 9.3%, which of course was much better than the medical management. And in that is not just surgical failure. Of course, you're also dealing with all the medical complications that come with ICH. And there again, there's a lot of conversations about the timing of surgery and whether or not early surgery would also decrease these complications. The effect is sustained at 180 days, and at all the endpoints time, the effect was favorable for MIPS. So if we talk more in terms of the reduction on hemorrhage volume with MIPS, so clearly it was better than medical management. But if we look specifically yesterday, there was talks about saying maybe end of treatment volume should be more in the 3 to 8 range. So in ENRICH, the average end of treatment volume was actually 7.2 milliliters, which is actually very good. And in terms of the degree of the ICH reduction, overall is 87%. So this just reinforces that in our practice, we really need to be aggressive with accomplishing these end of treatment volumes. And so how do you maximize your chances of accomplishing that? So in my hands, I favor deep cannulations in ICH. Of course, I'm trying to work very carefully in the great axis of the ICH as much as I can. I want to find the white matter tract interface early on in the surgery, know where that is, so that the rest of my surgery is really just backing out and getting hemostasis more so than thinking I need to go deeper. Now, I understand everybody has different variations of that, but that's what's worked well in my hands. And I like to work very systematically in quadrants. So that way I'm always going to 4 quadrants back out to 4 quadrants back out. That way you don't leave any corner behind. And it's just about being systematic so that then in your mind, it becomes very automatic. So this is a 67-year-old female, decreased level of consciousness as its left femoral hemorrhages. So this is a very nice MIPS case. anterior corridor. There's no spot sign. So the question here is, and feel free to participate. What approach would you use? Some people use an eyebrow approach. Some people use a low frontal incision and peel the forehead down. And then the question is, where would you cannulate? Would you go superficial in the middle of the hematoma, or would you go deep? So for the first question, in terms of what approach you would use, so in terms of eyebrow versus low frontal incision. So in our practice, we still use mostly low frontal incision. A lot of the cases are done emergently. So I tend to use a longer incision, peel the forehead down. But sounds like a lot of the audience at this point prefers an eyebrow approach for these cases, which gives you a straighter trajectory and, is a straighter shot down. But that's the trade-off in that decision. So then the next question was about where you'd cannulate. So if you want to go to the surface of the ICH, to the middle, or to the depth of the ICH close to the white matter tract interface. Okay, so if here the consensus is shifting. So you can do either. So it's either you cannulate in the middle, but then you're going to have to work farther in the depth and you don't know where the interface is. The technique is a little different. You have a spot sign, then early on I go after the spot sign, but otherwise in my hands, I like to go for the deeper portion, find the interface, and then work superficially more on my way out. And that enables me to just, make sure that then I don't have any hematoma left in the depth in case the walls of the white matter tracts collapse on me. So in this case, this is a case where we were better lucky than good. So in this case, we didn't do a very good job. This was a case a little bit emergent in the middle of the night. So, what mistakes did we make to leave more hematoma behind than what we expected? So if you look really and you look at the sagittal plane there, the issue is we went a little bit too high. With the yellow arrow, we had an angle that was a little bit too steep, which led us to then come to the bottom of the hematoma and not paying attention, not realizing that we had a lot of hematoma superior and posterior to us. And so we saw the white matter tract interface kind of cannulated out, the walls collapsed, and that's how we left that hematoma behind. And so this is a failure of lack of attention. Ideally, we should have, cannulated somewhat lower and really respected that great axis of the ICH, which would have made it easier. Or if we had chosen to continue with this trajectory, we should have paid more attention in realizing that we're going to have a lot of hematoma posterior and subcephala to us and be very cognizant of that during the resection and not just accept that the collapse of the white matter tracts what's the end of the resection. The patients still end up doing well. I mean, we got lucky. So here's a second case. If you want to play the video, please. So this is a patient that comes in. This is a case here of a hemorrhage from a location standpoint that is right putamenal, but here you see how here you have a little bit of edema around it, and then you have a component of IVH, and you see right there by the caudate where you get that communication between the ICH and the IVH. So, and the question here is, who would treat the ICH only? Who would treat the ICH and the IVH in this case? Okay, so we decided to treat both. And so when we deal with IVH, the key is really measuring on a modified Grape score, what the severity of that is. And so, I'm selective on that based on that. If you want to play the video here, so this is just to illustrate, should the open, low frontal, we do our dural opening. At that point, then we do our transsulcal dissection. So here, and this was in the early days where I was a little bit more aggressive than I needed to be with the dissection. And then we'll proceed with the cannulation. And so in this case here, the cannulation is really, you have two options. If you're trying to treat the ICH and the IVH, it's either you want to go deep and on your way out, then you need to find the ventricle, or your second option is to cannulate at the junction of the ventricle and the ICH component, so that early on you address the IVH, and then on your way back, you address the ICH. So here we're cannulating. Apologize, the video a bit slow. I mean, the point of the video is really, otherwise, if you want to go past it a little bit, is that, you know, as you get a little bit more, like go 2/3 through, yeah, there. So as you cannulate, now you get the hematoma. So here, you know, in the depth, there was a little bit of bleeding there that we coagulated. But the key of this video is on the way back, you also have vessels, and in this case, there's some lenticose striates vessels that we're actually traversing. So you want to be somewhat careful and being very selective in, you know, how you address the hemostasis in the depth, and, you know, not necessarily go overboard in terms of coagulating everything. So in terms of limiting our complications, it's really about using all your surgical adjuncts for hemostasis, and that being Surgicel, Surgiflow, what have you, thrombin, gel foam, and really ensuring that at the end, you get a very clean resection. So what was our complication rate in terms of rebleeding in the ridge? It was 3.3%. And so, you know, that also led to a 3.3% rate of craniectomies because of patients then decompensating. So the question of rebleeding, so is it really a timing issue? Is it relevant in the standpoint that the timing has an effect on the rebleeding, or is it more about working systematically, ensuring that we have good surgical technique? So we need to move away from this, you know, past kind of wording where the timing was felt to be that you had to wait a little bit and you wanted to wait. I think at this point, we clearly have a lot of data that early surgery is really the way to go. And this is reinforced here by a paper showing doing early surgery in MIPS cases that on top of it had a spot sign. And you can see that no extra surgical bleeding was encountered. There was no rebleeding. They compared it to a regular MIPS case, and the results were the same from a rebleeding standpoint. 4 patients deteriorated prior to the operation with having the spot sign, which again reinforces patient selection in terms of how to pick for surgery. In terms of how you optimize your surgical corridor, so there you want to work ideally in the long axis of the ICH. My preference is to cannulate deep or at the interface of IVH if you have it, because otherwise you don't want to later on struggle and try to figure out where your IVH component was. And then you want to know sometimes when to stop, especially in basal ganglion hemorrhages, where you may have some thalamic involvement. That's the portion that you then actually want to leave. Everybody in their mind should have some form of idea where these tracts are in order to then decide, as these are more surgical cases, we're not doing tractography, but then we decide if you're going to use an anterior lateral posterior corridor. So this is a 46-year-old male, was on Eliquis, comes in, has deteriorated now to a GCS of 4, large right frontal hematoma, a very significant amount of IVH involved. And the question is, what do you do with this? Do you operate? Do you not operate? So I chose to operate, and this is a case where then early on I went to find the interface. The key was really to decrease his modified grade score back to a 6, which is where the complication rates from the IVH component goes down significantly. And this patient eventually had a reasonable outcome, did not require a VP shunt. So this is just a small video here to illustrate when you're dealing with the IVH component. There it's a little different, so if you don't mind playing it. So there it's really, you start with the ICH, but once you get into the ventricle, then it's, in my hand, it's really suction only using a microconnoid, and you really want to be very careful there in respecting the pendula, and it's really about just engaging the clot and getting it out of the lateral ventricle, but then a lot of times it's necessary to go through the foramen of Monro and trace it down all the way in the 3rd ventricle. And that's really what gives you then that grade score to come down to a reasonable number. Another case, 57-year-old male, GCS 13, ICH score 2. So this is a case where, you know, again, the question is, how do you approach this? So it comes to the surface, right frontal, very favorable, has some communication to the ventricle. And the question is, you know, you do both? Do you just do the ICH? How do you optimize the entry? And so here, you know, it's really about recognizing the fact that this is a very favorable condition because the great axis of your hematoma is very much in line with the trajectory in getting to your ventricle and being able to address the IVH. So here again, you know, questions about going transcortical versus transsulcal because it comes to the surface. The question is, do you leave an EVD behind or not? For me, if there's extensive IVH, I do, just to make sure that they don't going to have postoperative hydrocephalus. And then the question is how far you go after the IVH. You stop at the 3rd ventricle at the foramen of Monro. And so this was our postoperative result. The ventriculostomy eventually came out, but had a good outcome. This is a case of lobar hemorrhage, seeing the fact that NRH was positive for lobar hemorrhage. We will show a little more cases of lobar hemorrhage. And this shows the difficulty in the lobar hemorrhage. You have a very large hematoma. Great access of the hematoma is very coaxial. You have a component of IVH, and it's not perfectly spherical. You also have these pockets to it, which makes it more difficult in order to accomplish a complete resection. And so the question here is really, what approach do you use? Are you going for an anterior corridor, lateral corridor, or posterior corridor, and do you address the IVH or not? So we chose an anterior corridor. I did not want to go towards the motor strip component to this. And so this is a case where it's difficult to get a complete resection. So this is a reasonable resection, but again, we're not getting the total end of treatment volume that would be our preference. And here it was very difficult to find the IVH. So even though originally my plan was to try to find it, then I aborted because, you know, here it's not involving the third ventricle. So it's a reasonable case to not necessarily have to do it. And so that's where I stopped there. But here the anatomy is difficult because you're coming somewhat from a lateral angle to get that access to the ventricle, which is a little bit in conflict with your great access of your hematoma. So in conclusion, MIPS is great for vascular applications. It's expected to increase beyond just the initial kind of inclusion criteria for MNRICH, but of course, a lot more research is needed and understanding where those boundaries are, and then understanding really the role of MIPS when you have anterior basal ganglia hemorrhages and higher extents of IVH. So the complications for MIPS and vascular application are low based on the NRICH trial. And, you know, these hopefully gives you some guidance in terms of how I look at it in terms of trying to improve your chances of success. Thank you.
Thanks, Jeroen. Jeroen, one question I have for you is you mentioned, you know, a deep cannulation for IB or ICH. For tumors, do you do deep cannulation, middle, or superficial?
So for tumors, I generally do superficial once in a while, and some very necrotic GBMs, I've done middle cannulation because I find that if the tumors are bigger, then it's very difficult to get those angles. So on GBMs, I'll kind of go in the middle of a tumor. But for the others, I mean, metastatic surface, and the others usually surface cannulation.
Jason, comments there?
Yeah, the question. So, and this question came up yesterday regarding anticoagulation. So these patients come in sometimes on Eliquis, Xarelto, et cetera. And in my hospital, we don't have at Nexia. So what do you go to, or do you have that drug? Because in my hospital, it's like $30,000 a vial. And so my hospital is probably never going to carry it. And we usually give FFP, DDAVP, and things like that. It's kind of plus minus as to what it works. I'm just kind of interested if you could speak on what you use.
So we'll use PCC. So in those cases, we don't generally have the Nexa available. So those cases, I will wait. I will try to wait 2 hours and repeat a scan. If I have stability on the scan, then I will do surgery, but that's been my experience.
Yeah, we use PCCs also. We do have Indexinab, but we don't like using it if we're taking them to the OR because it's 4 hours. And as soon as the drip's over, you run the risk of a rebleed. So you can have this false sense of security during surgery that the bleeding's under control. And then it opens up again. So the question was from Dr. Hockheimer, how do you deal with Plavix, patients on Plavix?
So we take patients on Plavix. Those are cases where once in a while I've left some gelphone and thrombin. So when you get a little bit of oozing, in those cases, I feel like that works the best. It tamponades the hematoma a little bit. And so we just give them platelets during the surgery, but we will do the surgery. It is a little bit more oozy. I will tend to leave a little bit more surgeon cell combined with some thrombin gel foam in those resection cavities.
And Jason, what about you for patients on Plavix?
Yeah, we kind of just throw everything in there. So FFP, DDAVP, along with platelets, kind of just load the rack, if you will.
Any other thoughts or comments from the audience about anticoagulation reversal for these patients? Yes, Annalise. There's a mic.
Oh, I noticed something that's kind of interesting coming out of the vascular surgeon's experience, where a lot of people do not necessarily respond to antiplatelet agents. And so they're doing various platelet function assays. You may be aware of the East Asian paradox, and certain groups do not respond to antiplatelet agents as we presume. So I noticed for grafts and other things, vascular surgeons are testing their patients because a lot of patients may not be responding to these antiplatelet agents. So just a thought.
There's ways to measure it, just at our institution, the P2I12 is a standout, so it's not logistically feasible in an emergent situation, but clearly if it's available to you in a short amount of time, it's a great adjunct.
In the back there.
Thank you, Dr. Coppens, great talk. A lot of learning from these cases. Really interested in doing more and more of these cases. What do you think in terms of is there any cutoff that you have in terms of the volume of the hemorrhage or location with your experience since you've been doing a lot of these cases?
Well, right now I don't have a perfect cutout. So what I would say is that the people we take right away are, the classic enriched criteria. Of course, as we go beyond that, then it's either young people that start to deteriorate. And, I've had, for example, a young lady that was giving birth, went into preeclampsia, had some 120 some milliliter, some huge hematoma. I'd have to actually probably present it. So a massive hematoma. But we went with MIPS, the craniectomy, left the bone off, and she actually did well. So I think you don't want to be rigid in your criteria. I think you want to start with the enrich, get buy-in from your neurologist. This is something where you want the rest of your hospital teams to be excited and have confidence in you. You don't want to go start with something that will get you in trouble. But once you have that system in place, then I think clearly, between the IVH and the ICH, it becomes based on your experience where you draw those lines. I don't think right now that I have a set determinate answer for you.
My second question is, in terms of, have you looked into, in these cases, you sort of increasing the MAPS before you close the case and after you're done with MIPS? I've talked to a few people, they've been talking tumor board in terms of to decrease length of stay in these patients. So have you done that ever? Or
No, but so they're usually hypertensive at the time we take them for surgery. At the end of the case, we just tell anesthesia, we want them normal tensive, and then we have the critical care team that helps with it postoperatively, but we don't augment or decrease at that point. We want to keep normal MAPS, and that's been our practice.
Dr. Sam?
Jeroen, great talk. Lots of good pearls. Relative to the anticoagulation issues, drugs are expensive. P2 is long acting. A really cheap solution for us that's worked well is, as you put the Surgisol in, a very judicious amount of fibrin glue, whatever you choose. Usually Tisiol, something that's not going to volume expand. Be careful; it'll expand to about 4 times the volume. For me, it's really changed the rebleed rates, particularly in the face of antiplatelets. I have the same experience with antiplatelet medication. We've had some paradoxical, the marinara craniotomy with a lot of red sauce. But I think that's it's a cheap solution. And, on the cannulation, have you been using the DWI to determine where to dock on the cannulation? You get a lot of cell density, you're going to get a roll on the tumor. Whereas if it's a little softer, I find it much easier to go to the depth. Once you take out the middle third of it, it's really hard to advance that port to go in, even if you don't use hyperventilation and mannitol to feed you. I actually find on the softer tumors, be they met or otherwise, it's just a lot easier to deal with the depth first, and then on the way out, let it deliver to you. And we've done exactly the opposite on MAPS. I think the venous congestion is the source of rehemorrhage. I don't think it's arterial. I think there's a substantial subpial venous injury on all of these ICHs, and there is an incidence of microvenous infarcts, and you get these congestive hemorrhages into that bed. And really managing the MAP when there's no autoregulation has been really helpful for us.